Good morning, Dr. Furie. We just made you a co-host, so you should present. Should be able to present. If you'd like to do that now, you can go ahead and do so. We usually start with an intro from our chair and then like a brief research or case presentation.
Okay. So do you want me to share my slides though?
You're welcome to if you would like to. Some people like to, but there's no need. We'll do Rich, our chair, will get on board, and then Carlene Moore, who I just made a co-host, will do a presentation, and then Brian, are you still going to introduce?
I certainly am. Hi, good morning, Dr. Furie. How are you?
Good morning, Brian. How are you? It's good
nice
to see you.
Yeah,
let me just see if I can get this band of light to go away. My shades are down, but it's still annoying. All right, no better.
Light is always a challenge. I've got a window that you wouldn't think it, but is a blinding beacon of light in all, when it's my background, it always shows up, so.
If I can shift everything forward, maybe I can get away from it. Okay, maybe better.
Good morning, Dr. Furie. Welcome.
Good morning. Thank you so much for having me.
Oh, quite the opposite. Thank you. We'll wait 59. We'll wait 2 more minutes before we get started. So we put on a little song and dance. So we have a few updates. Then Carlene will spend 5 minutes talking about her research, and then I'll introduce the lectureship, Janice Massey's lectureship, and then Brian will introduce you.
Sounds good. Thank you.
All right, it's 8 o'clock. Why don't we get started? We hit share screen. Okay.
Hi, this is Janice Manson. Thank you very much for coming.
Thanks, Janice. I get the privilege of talking about you, Janice.
Uh-oh.
All right, everybody. Welcome to Grand Rounds. I'll put the CME in there in a second. So good news on the COVID front. Our percent positivity is really quite low, about 3%. The census to the Duke Hospital has gone way down. But unfortunately, there's another strain out there. It's called BA2, and it's starting to hit parts of Europe. The bottom right is France. They're already starting to show an uptick. And yesterday, the FDA approved a 4th COVID shot. I'm thinking of getting a Moderna. I've had 3 Pfizers. Might as well mix, see if there's a little something from that. But Duke is still allowing us to be mask-free and eat and work in break rooms. And as I mentioned last week, we're going to in-person noon lectures with the residents. So one of those is on your schedule. Plan to do it in person. But fear not, there's plenty of reason to itch and sneeze. The yellow pollen is returning. This is, for those of you who are new, this is a infestation of the state where the pine trees just release gobs of pollen. It peaks in early April. It'll coat your car and it'll make you miserable if you have allergies. So another reason to sneeze and have a sore throat. Today is National Doctors Day as well as National Pencil Day. It's also the birthday of Moses Maimonides. In 1135, he was physician to the Sultan of Egypt and Syria, and an early proponent of smelling, observing, and tasting urine for diagnostic purposes. Sunday is the start of Ramadan, and April is Brain Tumor Awareness Month. All right, a little pat on the back for the department. It turns out that Newsweek is in on the game of best hospitals and best departments. They put out their rankings last week, and good old Duke Neurology, 12th in the US and 27th in the world, up from 57 last year. And if you see any of your neurosurgery colleagues, they are ranked 15th in the US. They're a little ahead of us in the world, but apparently the world isn't as good in neurosurgery as it is in neurology. Duke School of Medicine ranked 6th this year for research money in the same, and this is US News and World Report, and 16th for the most diverse. A little bit of research roundup. Katie Moore, one of our new Parkinson's researchers, was the lead author of a study looking at spacing out physical therapy is better than doing it all in a very short time. And Brad Coles continues to mine the AI world, looking at AI-induced triage for head trauma cases. We're still doing our Habitat for Humanity. Joel and Will are both looking for people to volunteer time and people to donate money. So contact Joel or Will if you're interested. Again, I'll put our CME code in, and I'll throw it now to Dr. Carlene Moore, who's going to give a brief presentation on her research program. Carlene, it's all yours. There you go.
Okay, good morning, everybody, and thanks for having me. I wanted to share a little bit about the research that's going on in my lab. Is everybody seeing the screen, the full screen?
Yep.
Okay, good. So the main theme in my lab is exploring the role of trip ion channels in migraine pain. Migraine occurs in about 10% of the world population. It's very popular yet understudied. There are 4 phases of migraine: the premonitory stage, the aura phase, the headache phase, and the prodrome phase. During the headache phase, the peripheral trigeminal ganglion afferents become activated. I'm gonna do my pointer. They become activated. When activated, they release mediators such as CGRP and PACAP. CGRP in turn leads to the degranulation of mast cells, which tend to release histamines, nitric oxide, TNF-alpha. Such histamines and TNF-alpha leads to vasodilation and vascular extravasation. The activation of these trigeminal ganglions, this signal is relayed into the trigeminal ganglion. The trigeminal ganglion also receives inputs from the trigeminal nerve V1, V2, V3, which includes the periorbital skin, which is also some interest to me. Afferents from the skin then become relayed to the TCC, which is relayed to the midbrain area, which is then relayed to multiple cortical areas, which results in the actual phenotypic expression of pain and the migraine-associated symptoms. So I'm more interested in the pain phase, the headache phase, and I'm going to introduce to you the transient receptor potential ion channels. These channels are involved in the detection of environmental changes and the trigeminal nociception. These trip ion channels are molecular sensors of chemical, thermal, and mechanical noxious stimuli to evoke pain. Here on the screen are listed the 4 most popular trip ion channels that have relevance to migraine pathophysiology, which include TRPV1, which is the noxious heat sensor. I'm going to give a plug out to TRPV1 because the most recent Nobel Prize in Medicine was awarded to David Julius to discover TRPV1, and also to Adam Pataputian, also was involved in the discovery of TRPM8 and piezo, so that these ion channels have recently gotten the recognition that they deserve from the Nobel Committee. So my lab, we're looking at the regulation of these channels in the migraine-like state. For these experiments that I'm going to describe very shortly, is we induce the migraine-like state in our mice using nitroglycerin, which induces a throbbing headache, which resembles spontaneous migraine attacks. And when we are doing, if we're doing a prophylactic study, such as when we pre-treat with botulinum toxin A, we inject that like a week ahead, and then we do the nitroglycerin injections. And then when we sacrifice the animals, before we sacrifice the animals, we do animal behavior studies on days when we inject the nitroglycerin. And then we sacrifice the animals and look for the changes of the trip ion channels in the trigeminal ganglion. For quick behavior study, here we see that when we inject nitroglycerin, we see a reduction in facial threshold, which we measure using this periorbital horn frame, where we measure the pain thresholds in that area. And so we see a reduction in threshold compared to our controls, and our prophylactic treatment of botulinum toxin reduced this threshold. Another measure that we use is to measure migraines pain is photophobia. Well, where the mice is introduced into a light dark box, they're free moving, they're able to choose which section they want to be in, the light or the dark. And migraine sufferers are known to be more sensitive to light. So this is a good readout of migraine behavior. Here we see that our NTG treatment mice tend to spend less time in the light, and this light sensitivity seems to be rescued by pre-treatment with the botulinum toxin A. Also, when we look at the trigeminal ganglion and look at the expression of the trip ion channels under the inflammatory conditions mimicked by the nitroglycerin, we see in every one of the trip channels we looked at, we were also looking at the ATP receptor, which is not a trip channel, but have been shown to be regulated in migraine pathophysiology also. We see an upregulation of our trip ion channels. Treatment with botulinum toxin A is able to reduce the expression of our trip ion channels, suggesting that the trip ion channels in the trigeminal ganglion is important in migraine pathophysiology. Also, we wanted to, as I mentioned earlier, when the CGRP is released, we get an activation of mast cells, mast cell degranulation. So we wanted to look at the role of the trip ion channels in these mast cells. The mast cells, here we are looking at mast cells in the G1 meninges. We just isolate the meninges from the skull caps. And here we see that, so the red arrow suggests is a mast cell that has degranulated, so it becomes a little bit more fuzzy and it tends to lose shape as opposed to the intact mast cells. And over a number of studies, what we found was that nitroglycerin we are able to see an increase in degranulation of mast cells in the nitroglycerin treated animals. And with botulinum toxin, we were able to see a statistical reduction, not a major reduction, but statistical reduction. So we wanted to know which trip ion channel could be involved, and we started with our favorite TRPV4, and we isolated mast cells from the bone marrow mast cells and assayed for calcium influx into these cells. We use Aspirin, which is a mast cell degranulator activator, using it's derived from wasp venom. And we use inhibitors for TRPV4. So GSK205 and HC0767 are TRPV4 inhibitors. And as you can see, we could block the influx of calcium into these cells because degranulation requires calcium to influx, and then they degranulate. And then we also looked at a TRPV4 knockout animals where we got mast cells from the knockout animal. First thing you could notice here is just baseline, just sitting in the dish, the TRPV4 knockout mast cells degranulate less basally. And when we stimulate with the Aspirin, we see a reduction in the granulation of the mast cells. And we were actually able to activate the mast cells with a high concentration of the TRPV4 agonist. Just activating TRPV4, we get an increase in the granulation, and that's like in the knockout mice. So this was a very short summary of the happenings in my lab. So my slide is stuck. So, but this is the summary anyways, that mast cells and skin cells in the dural meninges seem to be contributing to the sensitization of the nociceptive neurons that orchestrate inflammation and pain, and the trip ion channels in these cells, both the neurons, the mast cells, and also the skin cells, accessible targets for us to target for treatment, therapeutic treatment for inflammation and pain. Sorry, my slide quick, but
thank you. I'll take it over from you. Great job. So it's my honor to, Brian's going to introduce our speaker, but I'm just going to remind everyone of why we have the Janice Massey Leaders in Neurology lectureship. I think Janice, this is, I think, our 7th year maybe. So Janice began her career as a high school math teacher after graduating from Abilene Christian, along with her husband, Wayne. Wayne completed medical school first, and then while doing his internship and residency, Janice went to medical school at Georgetown and followed a path into neurology, which was very uncommon at that time, not at all uncommon now. Janice has been a leader in the world of neuromuscular myasthenia gravis and cervical dystonia for 30 years, with over 140 publications. In 2013, she was named the Myasthenia Gravis Physician of the Year. And in 2015, received a similar award from the American Association of Electrodiagnostic and Neuromuscular Medicine. She received the Duke Distinguished Medical Alumna Award in 2015, and in 2022, received the AAENM Lifetime Achievement Award. She's been vice chair of the American Board of Psychiatry and Neurology and on the board of directors of the American Board of Psychiatry and Neurology, and she's a past president of the American Association of Neuromuscular and Electrodiagnostic Medicine, and was the founding director of the Duke Neuromuscular Division. We've had quite an all-star group of Massey lectureships, starting in 2016 with Story Landis, then Eva Feldman, Louise McCullough, Rebecca Gottesman, Francis Jensen, last year, Dawn Kleindorfer, and this year we're pleased to have Dr. Karen Furie with us, and Brian McGrory is going to introduce Dr. Furie.
Well, thanks very much, Rich. I really appreciate it. And it's a true privilege to be able to introduce Dr. Karen Furie on this very special day in the life of the department, the Janice Massey Lectureship. Dr. Furie is a Samuel Kennison and Berta S. Kennison Professor of Clinical Neuroscience, as well as Chair of the Department of Neurology at Brown. Dr. Furie obtained her undergrad and medical degrees from Brown University before completing residency and fellowship at the same institution. She joined, after training, the faculty at Harvard Medical School at MGH, rising to become the director of MGH Stroke Service and at the J. Philip Kistler Stroke Research Center. It's honestly a very intimidating proposition to attempt to introduce Dr. Furie, but perhaps her career could best be encapsulated as her having, essentially earned a global reputation for a sustained record of creative, intellectual, and operational leadership within very large, multi-institutional, multi-domain clinical translational studies that has crossed different elements of stroke, both acute stroke and secondary prevention, many of which of her studies have changed practice and really entered the lexicon of the stroke physician in his or her daily practice. In terms of her clinical trial leadership, she occupied very senior roles within the WARCEF and the WASID trials, and most recently was on the operations committee of the IRIS trial. She was the PI of the Spotrius Center at MGH, and many of us will be familiar with the MR Witness study, which arose from that collaboration. And most recently, she was the PI of the Spirit site within StrokeNet. Other leadership positions Dr. Furie has occupied includes chairing the AHA Stroke Council, and she was also just named the editor-in-chief of the Journal of Neurology, Neurosurgery, and Psychiatry, which makes her the most recent member of an extremely exclusive group of neurologists that started back with Kinnear Wilson. On top of all of this, she's received countless awards for teaching and clinical care throughout her entire career. Having worked in Dr. Furie's department for 3 years, I would actually say that beyond all of this, her greatest attribute is really the warmth and the kindness and support she exhibits to all members of her department, including and perhaps especially trainees and junior faculty. She's mentored dozens of junior researchers and inspired the careers of many hundreds more, and some of her trainees have themselves gone on to occupy very senior positions. Anyone who's at the ISC this year, for example, one of her trainees actually gave one of the plenary sessions, for example. And on a personal note, I would just say Dr. Furie is someone who's always been very supportive of me personally, and that's something for which I'm extremely grateful. So the Janice Massey lectureship this year is delivered by Dr. Carlene Furie. I'm going to turn it over to you.
Thank you so much, Brian. I'm incredibly flattered by your introduction and very honored to be amongst the other speakers for the Massey Lectureship. So thank you so much for inviting me. Let me share my screen. Okay. Are you all seeing my first slide?
Yes, we are.
Okay.
You're still in slide mode, but they're all up there.
There we go.
There you go. Yep.
Great. Well, thank you. So I was inspired to choose this topic of the many options for dual antiplatelet therapy based on discussions that we have on the ward service almost every day, it seems. This has been a very rapidly changing area of stroke. And although it doesn't get the same type of attention that acute thrombolysis or mechanical thrombectomy does, this has been an area that has changed dramatically since I was a resident and stroke fellow. And I thought it was worth just going through this history, which has really spanned decades, to give folks a sense of what are the considerations and how strongly supported are these various dual antiplatelet regimens. These are my disclosures. They're not specifically relevant to today's presentation. So TIA in minor stroke. This is an area that virtually all of the antiplatelet trials focus on. Statin therapy is also focused on this one area. And that's because TIA in minor strokes are usually due to atherosclerotic and non-cardioembolic mechanisms. These are also factors that portend to a poor outcome within a relatively short period of time. So within a year of a TIA, for instance, a quarter of patients die. After a TIA, there's a significantly increased risk of stroke. It's almost 19% by 10 years. And if you combine MI and vascular death, it's over 40%. In NASIT, patients who had a hemispheric TIA had a 90-day stroke risk of 20%. And in fact, the risk was higher after TIA than it was after hemispheric stroke. This is going back quite a while, but in 2000, this was one of the really sentinel papers that identified TIA as a marker for bad outcomes. This data came out of the Northern California Kaiser system. They looked at over 1,000 patients who came in with TIA. And as you can see, within a relatively short period of time, half of these events occurred in less than 2 days. Approximately 11% had had a stroke and 15% had other adverse outcomes, death, hospitalization, or recurrent TIAs. And if you're a more graphically oriented person, you can see this displayed here, that very quickly after TIA, predominantly in that first week, you see an increase in strokes as well as the other adverse events that I discussed. Overall, about 20%, so 1 in 5 strokes, are recurrent after an initial stroke or TIA. So this early period is really critical for preventing stroke recurrence. And that's why so many of the secondary stroke prevention trials have focused on this particular epoch in the whole spectrum of stroke management. Antiplatelet therapy has really become the focus of management for non-cardioembolic stroke. And we don't have enough time this morning to go into all of the data that supports the monotherapy with antiplatelet agents over placebo. And I think I don't have to convince this group that antiplatelets are effective in this population. But given that aspirin, clopidogrel, as well as Agronox, which is dipyridamole aspirin, are all reasonable considerations for management of secondary stroke prevention, folks have gotten creative over the last decade, looking at the various combinations to see whether combination therapy, also frequently termed DAPT for dual antiplatelet therapy, would be better than monotherapy for stroke prevention. And the reason that there's at least a scientific rationale for this is that the various antiplatelet agents work on different targets. Clopidogrel and ticagrelor are going to be working on ADP-mediated platelet activation, inhibiting that mechanism of cyclic AMP activation. Dipyridamole and celastazole block phosphodiesterase adenosine uptake. And of course, aspirin is working on cyclooxygenase. And therefore, in theory, if you blocked each of these mechanisms, you could effectively block all platelet aggregation. And the trade-off here is that as you start adding more and more antiplatelet drugs, you obviously increase the risk of hemorrhage. And so most of these trials have been designed to either demonstrate non-inferiority or mild efficacy relative to safety. And safety is virtually always going to be some form of hemorrhagic outcome. So I wanted to kind of give an overview of where we're headed in the next 30 minutes or so. I'm going to talk about these various combinations, and some may be very, very common to you, like clopidogrel and aspirin, but others are more exploratory, like combinations of celastazole and various antiplatelet agents. But people are thinking about how we can best pair these to optimize the antiplatelet effect and minimize hemorrhage. The other issue just to keep in mind with all of this is when these drugs are started relative to the index TIA or minor stroke. And this is something that has really evolved since the earliest trials like MATCH back in 2004. I also put the years of the primary manuscript publication on here to give you a sense of just how long people have been chipping away at this. MATCH came out in 2004. And here we are in 2025, and it took almost that long, it's 2022, it took almost that long for evidence to emerge to make this a standardized recommendation. So this was not a slam dunk by any stretch of the imagination, and it required modifying the various study designs, and in particular, trying to optimize that sweet spot for patients who would derive maximal benefit with minimal risk. So this is going to be a whirlwind, but bear with me as we go through some of the trials that help support this recommendation. And we'll start with aspirin and clopidogrel. The MATCH trial was the first. So this question asked whether clopidogrel and aspirin was superior to clopidogrel alone in preventing recurrent ischemic events. And this study tried to target high-risk individuals. It was double-blind and placebo-controlled, so it was a very rigorous trial. And it enrolled close to 8,000 patients within 3 months of their stroke and followed them for 18 months. So look at that 3 months. This was back when people thought that initiating secondary stroke prevention was not something that had to be done immediately, that you had plenty of time to do that within months of the event. So patients were randomized either to clopidogrel and aspirin or to clopidogrel. They had a TIA or minor stroke within that time frame. And because they had to be high risk, they had to have some other high risk characteristic, either a clinical history or association of risk factors. This study excluded patients with any history of GI bleeding ever. So they really wanted to minimize side effects as much as possible. And then they had a primary outcome composite of ischemic stroke, MI, and vascular death, as well as rehospitalization. primary outcomes came out in 2004 and did not show any significant benefit to the combination of aspirin and clopidogrel. As you can see, the p-value comparing the two arms of the trial was not even close to significant. In contrast, if you look at the hemorrhagic complications in this group, you can see that patients who were treated with the combination of aspirin and clopidogrel had a significantly higher risk of primary intracranial hemorrhage. This graphically depicts the various subgroups of that primary outcome: stroke, MI, cerebrovascular death, and rehospitalization. And as you can see, even if you broke down the individual outcome events, the combination of clopidogrel and aspirin was not significant for any. Sorry. If you look at hemorrhage, you see exactly the reverse. And that for most of the hemorrhagic groups, most significantly the life-threatening group, clopidogrel and aspirin was associated with a significantly increased risk of hemorrhage. And this twofold increase is something that is going to be a theme, because it turned out this twofold increase in hemorrhage was present in other trials looking at this combination as well. Overall, if you look at all of the subgroups that were analyzed and matched, the only thing that seemed to indicate that there might be a subgroup that would benefit from this combination were the patients who were treated very early after the qualifying event. And so this got people thinking that perhaps, just as in acute coronary syndromes, the benefit might be derived from early initiation of therapy and not this sort of subacute, more chronic intervention within months of the event. So next up came Charisma, clopidogrel for high atherothrombotic risk and ischemic stabilization, management, and avoidance. Again, these were patients who were at high risk for atherosclerotic events. Over 15,000 patients were randomized. They either received clopidogrel or placebo, and everyone received aspirin. So this was a combination therapy, DAPT versus monotherapy aspirin. The high risk characterization was either a history of coronary artery disease, cerebrovascular disease, or peripheral artery disease, or two major or one major and two minor or three minor risk factors. Like Capri, which was the trial that demonstrated a benefit of clopidogrel over aspirin in the overall group of patients who had any manifestation of cardiovascular disease. This trial also broke patients down into cardiovascular, cerebrovascular, and peripheral artery disease. And as you can see, in none of the groups was there a significant difference in patients treated with combination therapy versus monotherapy. Even when patients were broken down by the primary outcome, the overall combination of MI, stroke, or cardiovascular death, there was no statistically significant benefit to treatment with combination therapy. And this study did demonstrate that the risk of severe bleeding was not increased with combination therapy, but there was an increase in moderate bleeding, which led to transfusion. So this is what you would expect in a study that is looking at more aggressive antiplatelet therapy. And it's odd that some of the later studies that I'll be discussing may show a benefit in an antithrombotic event without that increase in bleeding. And that one is hard to wrap your head around. SPS3 trials selected a particular subgroup of patients. These were patients with symptomatic lacunar infarcts. And of course, small vessel disease is really a conundrum for vascular neurologists. The mechanism is partially atherothrombotic, but it's also related to lipohyalinosis. And progressive small vessel disease can be very insidious and difficult to control, even with aggressive combination therapy and risk factor management. So SPS3 asked the question of whether combination therapy might be superior to aspirin alone in patients with small vessel disease. And again, this was a highly rigorous study. It was international. They enrolled over 3,000 patients within 6 months of the event. So this is still kind of a subacute or chronic enrollment period, and followed patients for over 3 years. And as you can see, yet again, no benefit from the combination of clopidogrel and aspirin in this high-risk population. But they did see a twofold risk in major hemorrhage. So very, very similar to what was seen in the MATCH trial. So now we sort of emerge into the more modern age. Finally, people looked at these studies and said, we're seeing the same thing. If you enroll patients 3 to 6 months out, you don't see a benefit for reducing recurrent stroke or other major arterial events, and you see a doubling of hemorrhage risk. Well, what if we replicate ACS and start to enroll patients much earlier in the time frame and treat this as more of an urgent or acute therapy? So Chance and Point were both trials designed to look at this particular question, and they were both double-blind placebo-controlled randomized trials. Let's compare the two. So they were slightly different. In Chance, clopidogrel was loaded with 300 milligrams, then 75 milligrams a day, whereas in Point, they used a 600 milligram load. There's really no evidence-based study to point to say that one was better than another. I think you're just seeing disparate practice, and you're seeing one study that was run out of Asia, where there's a reluctance to use higher doses of antiplatelet or antithrombotic therapies in general, compared to a study that was done primarily in the United States. And then they were using different doses of aspirin, 75 milligrams in Chance and up to 325 milligrams in Point. The definitions of TIA and minor stroke are similar. They looked at a 90-day outcome, and they had approximately the same patients, roughly 5,000 patients in either trial. Chance was the first study to show a benefit to the combination of clopidogrel and aspirin compared to aspirin. So this was a real game changer in stroke. And the only concern here was that it was done in an Asian population. And it raised the question about whether the effects might be different. Certainly risk factor modification in Asia, it was quite different than that in the US, with very high rates of uncontrolled hypertension. In terms of safety risk, you can see that for the most part, looking at bleeding risks, there was no statistically significant difference between the patients treated with aspirin and clopidogrel. And again, whenever I see this, it does cause some consternation, because I do expect to see anything that's a more effective antithrombotic to show some signal of increased hemorrhage risk. The next trial out of the gates was Point. And again, Point showed a benefit to the combination of clopidogrel and aspirin. These trials were enrolling patients within 12 to 24 hours of their index event. And as you can see, there's an absolute risk reduction of 1.5%. The hazard ratio, however, was 0.75, and that was statistically significant. In Point, there was a difference in the rate of hemorrhages, and it was statistically significant. So again, this is at least biologically consistent with what you might expect in an antiplatelet study. And then the question was, well, the duration of treatments was different in Point and in Chance. What seems to be the best time frame for treating patients? So within 0 to 30 days, as you can see, there's both a benefit in terms of antithrombotic effect and a small increase in risk of hemorrhage. But out beyond 30 days, you lose that benefit for antithrombotic protection, very much like the previous trials I showed that enrolled patients in this later period, but a persistent hemorrhage rate. And that's why the recommendations that have come out have really recommended that dual antiplatelet therapy be started early and only maintained for several weeks after TIA or stroke. So these studies pretty much demonstrate that clopidogrel and aspirin is effective if you started early, so if you started within a week of stroke, and that it is effective at reducing the risk of recurrent events in patients, especially those in a high-risk category. People have considered what the optimal treatment period is and have settled on this 21 to 30-day regimen. I pretty much use 21 days in my practice. If you're enrolling patients or starting them, initiating them on therapy beyond this period, there's an increased risk of hemorrhage without a benefit to reducing recurrent stroke risk. And so if you're seeing patients further out in the more chronic state, it is not worth starting them on this particular regimen, and they should be started on monotherapy. So there are official recommendations, which we're currently following based on ESO, are that in patients with non-cardioembolic minor ischemic stroke or high-risk TIA, if it's within the past 24 hours, they recommend 21 days of aspirin and clopidogrel followed by monotherapy. And the ASA-AHA recommendations are similar. They were a little bit more lenient in terms of the duration of therapy. Again, I think most people are leaning toward the 21 days. And so this is what we're currently following in our practice. I'll talk a little bit about aspirin and sustained release dipyridamole. This used to be a very appealing combination. And I have to say, it's very much dropped out of routine practice for a couple of reasons. I'm going to skip over the many studies that looked at just plain dipyridamole aspirin, which were negative trials. Talk about the first positive study, which was ESPS2. And this uses a sustained release formulation of dipyridamole. And this study enrolled patients within 3 months of their TIA or stroke. It was a factorial design, and it enrolled not only patients on combination therapy, but monotherapy as well. And it asked the question as to whether these drugs alone or in combination were superior at preventing stroke death or a combination of stroke and death. And patients were followed for 2 years for those endpoints. ESPS2 did demonstrate, as you can see here, I think very graphically, that the combination of sustained release dipyridamole and aspirin reduced the risk of stroke compared to placebo. The magnitude of that risk was about 23%. The absolute risk reduction was 3% at 2 years or 1.5% annually. Again, very similar to what we saw in other trials. And for the primary endpoint that combined stroke, MI, and vascular death, there was a relative risk reduction of 20% with the combination compared to aspirin. And again, that's all graphically depicted right here. So this was the first trial to suggest that this combination might be beneficial and superior to monotherapy with either aspirin or sustained release dipyridamole. The adverse event profile in this trial did not differ significantly across comparing the combination to monotherapy, although in other trials there was more of a difference. But it is worth noting that a significantly higher proportion of patients on the combination therapy stopped taking the study drug because of GI side effects and headache. And this has been a limiting factor of using sustained release dipyridamole and aspirin. Aspirin looked at this combination as well. They compared aspirin and dipyridamole to aspirin alone. They looked at over 4,000 patients. This was an international trial, open label. They too had a composite vascular outcome. And as you can see here, there was a marginal difference in the two groups, which with essentially the two curves beginning to distinguish themselves at about approximately 2 years, but no significant difference really in the ischemic events. And it's important to note that this, the fact that the curves start to change at 2 years is important because at 2 years, only 73% of patients were actually on the combination, 92% were on aspirin, and they were on a very wide range of aspirin. So, conventionally, doses of 30 milligrams of aspirin would be considered too low, at least in Western countries. And so there are a lot of issues with the quality of this trial in that the comparator might have been aspirin that was being dosed at too low a dose. And this conundrum that you began to see a difference in the groups at 2 years when a high proportion of patients were not even taking the drug. In a meta-analysis that really utilized data from ESPS2 and Aspirin, you can see that overall there is a benefit to combination aspirin and sustained release dipyridamole over aspirin alone. And as a result of this, for many years after these studies came out in the early 2000s, patients began using these drugs. The main problem, however, was that the side effect profile was very unfavorable, and a high proportion of patients discontinued early on due to headache or GI side effects. The next trial that really tried to move the combination forward was PROFESS. This was a 2x2 factorial design, which incorporated not only antiplatelet therapy, but also antihypertensive therapy. They had to study over 20,000 patients based on their power calculation. This study was, the sample size was recalculated 3 times before they settled on this very large study. Patients were enrolled within 90 days of their qualifying event, and the primary endpoint was time to recurrent stroke. Patients were studied on these combinations of either clopidogrel or sustained release dipyridamole and aspirin for up to 4 years. Interestingly, when they first conceived this trial, it was supposed to be a combination of clopidogrel plus aspirin versus sustained release dipyridamole plus aspirin. But based on the previous studies that I've just discussed, they decided that there was not equipoise for combination therapy with clopidogrel in this time frame, and so it became monotherapy with clopidogrel. It's also worth pointing out that over half the patients in PROFESS had small vessel disease. This has been a feature of many secondary stroke prevention trials. SPS3 obviously targeted this population, but it's important when you think about stroke in its entirety that most of these trials are looking specifically at small vessel disease, and these patients have the lowest risk of stroke recurrence and the best outcomes. PROFESS did not demonstrate a positive finding, and I'll get to that in a minute. But there also weren't significant differences in the risks of hemorrhage. And the reason that I talk about the outcome of this as being somewhat hard to digest is that this wasn't designed as a superiority trial. It had a non-inferiority outcome. In this design, the null hypothesis is that the drug will be inferior. And so the alternative hypothesis under consideration is that it's non-inferior. In these types of trials, you have to set a non-inferiority margin. In this trial, it was set at 1.075. The hazard ratio was 1.01. And because 1.075 is within this range, they could not reject it. And therefore, they could not reject inferiority. 11% exceeded the margin, which was 7.5%. Therefore, Agronox, which is the combination of sustained release dipyridamole and aspirin, could be 8% better or 11% worse than clopidogrel. As I previously mentioned, they did see this increase in headache that led to early discontinuation of the drug. And again, in clinical practice, this was a major barrier to getting patients started and compliant on this regimen. Aspirin and celastazole is relatively new, and there's not great evidence for it, but I at least wanted people on this conference to consider it. There are 2 trials out of Japan that have looked at this. The first is ADS. They looked at about 1,200 patients. They randomized them either to aspirin and celastazole or aspirin and followed them to see whether patients had neurological deterioration, recurrent stroke, or TIA. The study was stopped prematurely. The sample size was projected to be 2,000, but because of slow enrollment, they stopped it early. They saw no difference in the primary outcome in the patients who were on dual antiplatelet therapy versus monotherapy, but they also didn't find a difference in patients with intracerebral hemorrhage or subarachnoid hemorrhage. I don't know how much a weight to put on the safety outcome, given that it was underpowered. So, we don't know whether if they'd achieved adequate sample size and followed patients out as long as they intended, whether there might have been a safety signal there. The other study that looked at this is called CSPS, Celastazole Stroke Prevention Study. This was looking at high-risk patients, so they had to have either a 50% or greater stenosis of an intra or extracranial vessel, and one or more vascular risk factors. They enrolled over 1,800 patients, but again, very similar scenario. The sample size was calculated to be 4,000 patients, and because of slow recruitment, they stopped early. They randomized patients to either dual therapy or monotherapy. This was a very strange study design. So monotherapy could be aspirin or clopidogrel, and you could pick your dose of either drug. And then if you were assigned to the dual antiplatelet arm, you got celastazole added to either of those other antiplatelet drugs. Patients were followed for recurrent symptomatic ischemic stroke. And as you can see, they did suggest that there was a reduction in stroke risk with dual antiplatelet therapy versus monotherapy. But I think this study is very problematic because of its design. And even though it was reported as positive, it's very hard to know how to interpret these results. And as a consequence, this has not been widely adopted in any of the recommendations. They did a subgroup analysis of that study to ask the question about whether the combination of aspirin plus celastazole was different in terms of outcome from clopidogrel and celastazole. And they only were able to demonstrate a benefit in the patients treated with clopidogrel and celastazole. They acknowledged that because this was a subgroup analysis, they may have been underpowered to detect a difference in the aspirin group. They did indicate that there was no significant safety signal indicating that that the combination did not significantly increase the risk of hemorrhage. But again, I think that in order for this particular combination to move forward, it's going to be important for it to be replicated in a more heterogeneous patient population with a more rigorous study design. Finally, my last combination is aspirin and ticagrelor. These are really much more recent studies that have looked at novel P2Y12 inhibitors. So both ticagrelor and clopidogrel, if you'll remember my mechanistic slide, are operating by the same mechanism, inhibiting CYP2C19 and therefore P2Y12 platelet activation. Clopidogrel is a prodrug, so it has to undergo hepatic metabolism before becoming an active drug. In contrast, ticagrelor is an active drug, so its onset is much more rapid than clopidogrel that has to go through that activation phase. And there are other drugs that can affect the activation through these hepatic enzymes. The PRINCE trial just asked a very fundamental question, and that was whether the combination of ticagrelor and aspirin was more or less effective at reducing platelet reactivity compared to clopidogrel plus aspirin. So they looked at patients who'd had a minor stroke or TIA, who presented within 24 hours of symptom onset. They were assigned to either ticagrelor and aspirin or clopidogrel and aspirin. And then they had their PRU, which is their platelet aggregation metric, measured at 90 days. Like the other trials that I mentioned, this trial also was stopped prematurely because they felt that the efficacy was met. In this slide, you can see that the rate of platelet aggregation at 90 days was lower in those who received ticagrelor versus those who received clopidogrel. There was a lower rate of platelet aggregation observed with the ticagrelor patients who had the CYP2C19 loss of function alleles. And I'm going to come back to that in just a few moments. There was no difference between the groups in terms of the secondary efficacy outpoint of stroke, and the rates of hemorrhage were very similar within the two groups. So this was more of a concept or proof of concept design. These are just the slides that summarize the efficacy. Again, no difference in stroke occurrence, some suggestion of benefit in patients with large artery atherosclerotic disease. And the only increase in bleeding was seen was minimal bleeding in patients who were on the combination of ticagrelor and aspirin. The TALIS trial looked at the combination of aspirin and ticagrelor compared to aspirin alone. This was a double-blind randomized trial, 11,000 patients. This was an international trial. Patients had to have non-cardioembolic acute ischemic stroke with an NIH stroke scale score of less than or equal to 5 or a high-risk TIA. Drug was prescribed within 24 hours of onset. These are the two arms. They each include a loading dose and then combination with either dual antiplatelet regimen. The primary outcome was stroke or all-cause death. As you can see, they were including this group of patients with minor stroke or TIA. Patients had to have CT or MRI to rule out any other pathology or hemorrhage. And there were many exclusion criteria, particularly around acute stroke therapy, which is relevant to how we currently manage acute stroke patients. Skip that. As you can see, there was a statistically significant benefit to patients treated with ticagrelor and aspirin, an absolute risk reduction of 1.1%. The hazard ratio was 0.83. The number needed to treat was 92. If you look solely at ischemic stroke, you can also see an absolute risk reduction of 1.2% for ischemic stroke alone. And if you consider overall stroke or death, you can see that both the primary, secondary, and exploratory endpoints suggest a benefit for the primary as well as the secondary endpoint. And they looked at disabling stroke and were also able to show that combination therapy reduced the more severe strokes. The issue that perhaps even if recurrent events occur, they're not as disabling. There was an interesting analysis done based on NIH stroke scale score, and they demonstrated that the greatest benefit was derived from patients who had more mild strokes. And this had been seen in the Socrates trial as well. And this was the analysis looking at disabling strokes. And as you can see, the patients who were treated with ticagrelor and aspirin compared to monotherapy had a lower risk of disability. In terms of hemorrhage risk, there was an increase in risk associated with ticagrelor plus aspirin versus aspirin, which one would expect. And overall, there was an increase in discontinuation of the study drug as a result of that bleeding risk. So, these are not trivial hemorrhages in the TALIS trial. We talked about minor hemorrhages increased in some of the other dual antiplatelet trials. But in this one, the increase was in severe bleeding as well as intracerebral hemorrhage. So in conclusion, in this patient population with non-cardioembolic stroke, the combination appeared to be superior to aspirin alone with an outcome at 30 days, but it was offset by a higher risk of hemorrhage. The combination of ticagrelor and aspirin, though, is a reasonable alternative to patients who have one of these loss of function alleles that would make them derive less benefit from combination therapy with clopidogrel. So very quickly, clopidogrel is effective, as we've talked about, but about a third of the population has one of the loss of function alleles that reduces the efficacy of clopidogrel. Only a small proportion of Caucasians have the poor metabolizer phenotype. But laboratory-defined clopidogrel non-responsiveness, which is done with a platelet aggregation assay, can be as high as a quarter of all patients. As a result of this, there's a black box warning that warns prescribers that both based on genetics, but other factors, such as dietary factors, clopidogrel activity may be diminished in some patients. There have been multiple loss of function alleles that have been identified, but increased function alleles as well. It's possible through genetic testing to look at both the heterozygote and homozygote states, which can classify patients as high, intermediate, or poor metabolizers. And there's some evidence from cardiovascular studies that these differences in metabolism translate into differences in outcome. And so CHANCE-2 provided an opportunity to ask the specific question as to whether the combination of aspirin plus ticagrelor was beneficial in patients who had these loss of function alleles. So CHANCE-2 identified patients with TIA or minor stroke and a CYP2C19 loss of function allele and randomized them either to ticagrelor or clopidogrel. Everyone received aspirin. And you can see that the patients who received the ticagrelor and aspirin had a significantly lower risk of the outcome event. I apologize for the lag here. I don't know why they don't go quickly. And for almost every subgroup, you can also see a benefit in this population to patients treated with ticagrelor and aspirin. So final thoughts here. For non-cardioembolic TIA and minor stroke, the best evidence for dual antiplatelet therapy is aspirin and clopidogrel, which has been studied for decades. We currently have sort of focused on 21 days of therapy with the goal to initiate therapy as quickly as possible after the index event. If patients are identified as having the CYP2C19 loss of function alleles, or, and this is a big or, have evidence of a lack of antiplatelet response with a platelet activation study, ticagrelor and aspirin is a reasonable alternative. Aspirin and sustained release dipyridamole can be considered, but again, it's really fallen out of fashion. It hasn't been as well studied. The trials that looked at this combination were not as rigorous as those of other agents, and it is associated with a very significant adverse effect profile. There really isn't enough evidence right now for combination aspirin and celastazole. These drugs are only effective if started early. All of the previous trials demonstrated if you're starting them months out, you're only increasing risk of hemorrhage. And no patients who received thrombolysis or endovascular treatment were included in any of these trials. So that's something for the future. So I want to thank you very much for your time. I hope that was comprehensible. We covered a lot of ground with regard to clinical trials, but I think this is going to continue to be an active area of research as newer drugs that work on these antiplatelet targets emerge. So thank you very much.
Thank you, Dr. Furie. So anyone who has a question, just either put your name or your question in the chat and we'll get to you. You didn't mention loading after the first few slides. What's up with loading when you start these medicines? Yeah,
so it's, again, this is one of the areas that has not been incredibly well defined from a scientific basis. Oftentimes we talk about whether or not we're going to load based on patient characteristics, like whether or not there's evidence of a particular hemorrhagic transformation on the imaging. I would say that the default and the recommendations are to start with a load unless there's a contraindication. But I think there's a significant spectrum of clinical judgment that's involved in deciding whether you're going to load or just start therapy.
Swaroop, you have a question?
Dr. Furie, thank you so much for summarizing such an essential clinical question that comes up, and just to also give a historical perspective. In your clinical practice, how often and under what circumstances do you check for a Plavix assay? Is it when a patient shows up with a recurrent infarct on Plavix or DAPT? How do you sort of tackle that?
So we have been, I have to say our practice has changed dramatically in the last year. And so now we're pretty routinely getting those assays done on patients who present and might be eligible for dual antiplatelet therapy, and certainly on all patients who are going to require DAPT because they've undergone angioplasty or stenting. We are sort of, wring our hands over this issue because there are no point of care genetic tests. And yet the trials are really looking at the genetic tests to guide, potentially guide selection of antiplatelet regimen. And we're reliant on the platelet reactivity assays. And so we've talked internally about our comfort level with that and would really prefer that there was some standard identified that we could rapidly use during the inpatient evaluation and give us greater confidence that we were matching our practice to the existing studies.
Thank you. Brian?
So, Dr. Furie, thank you for the talk. I wanted to ask your opinion about the combination of a low-dose NOAC with aspirin for secondary prevention of ischemic stroke. I mean, people talk a lot about the COMPASS trial and how that may relate to stroke secondary prevention. Of course, it was a primary prevention trial in patients with stable cardiovascular disease, but I noticed that a lot of people are now talking about this combination. Just wanted your thoughts on that.
Yeah, again, this is a controversial area. I think that it's a compelling question as to whether that might be an effective regimen. As you say, there is some evidence to support it. It's a combination that's going to be looked at in Captiva as well. So that's going to be looking at intracranial disease. And, the DOACs, the DOACs really haven't had tremendous promise with regard to non-cardioembolic mechanisms of stroke. And just recently, there were several trials that suggest maybe it's not as wonderful as we thought. It certainly is primary therapy for prevention of secondary stroke and atrial fibrillation. But we may not be seeing the same benefit in other stroke mechanisms. Having said that, I do think it's worth pursuing that. Small vessel disease and intracranial atherosclerotic disease are very high-risk conditions with regard to long-term prognosis. And none of the therapies that we've seen tested thus far convincingly prevent the progression of leukoariosis or silent brain infarction. And even though if those are not contributing to symptomatic recurrent strokes, they certainly are contributing to long-term cognitive outcomes in patients. And it would be wonderful to have a more effective therapy.
So we'll have one last question from Wayne, and then Janice, if you're still there, we'll finish up with a comment. Wayne, why don't you?
Well, good morning, Karen.
Hi, Wayne.
Yeah, congratulations for the Janice lecture. So, over the years, we learned so much from those different combinations. Stroke is just, cardiovascular complications. And the inhibitor platelet just one of the strategies. I think the struggle we at a stroke belt in North Carolina, particularly in the buccal stroke belt, is really how to, maximize, the stroke reduction strategy with minimum cost to the patient. So, the medication we know a patient will surely taking the one actually they can affordable. So how we can really best balance, to do a cost effectiveness, I actually tend not to check too much about it, the Plavix, and because it costs money and genetic profile takes a lot of money, the platelets inhibition test not too expensive. So how we should be to, implement the evidence from clinical trial to the real world practice, which are very different in a stroke belt.
Yeah, no, you're very correct. And, the cost of the genetic testing is not inconsequential. It was about $500 a study, but that figure is several years old. It may be considerably more or less now. I haven't looked to update it, but you're quite right. And in the outpatient setting, I don't check it. And for just that reason, it'll be denied by many insurers. During the acute hospitalization, when I think it's most relevant to prevent recurrent events during that early phase, the cost of that test is going to be bundled into the DRG. So the patient isn't, in most cases, the patient isn't going to be responsible for that charge. But it's not, it's not an unrealistic approach to take to just start the dual antiplatelet therapy like we were doing previously and use clinical guidelines in order to determine whether your combination regimen is effective. It's still only a small percentage of patients in our population that is likely to have the loss of function allele and the poor metabolizer phenotype with the increased, decreased efficacy of clopidogrel. It's much higher in other populations. So I think in the United States, it's not an unreasonable thing to say, I'm just going to treat based on guidelines, and I'm not necessarily going to do the genetic testing.
Yeah, thanks, Karen.
So Karen, Janice, I think, is not on anymore, but she sends her many thanks for an excellent and clear presentation. So I'm just going to ask one last question. Is there any divergence between stroke trials and cardiovascular trials in terms of these antiplatelet therapies?
The data are pretty consistent. I would say the stroke patients tend to be a little bit more fragile. They're older, and the risk of intracranial hemorrhage is greater because they have an ischemic bed that, with necrotic tissue that may transform with hemorrhage. The cardiologists really don't have to contend with that issue. But for the most part, I think if you keep your eye on the kind of the similar track record of trials in cardiology, we're following almost the same path and finding the same characteristics, that dual antiplatelet does have benefit and that you have to treat early. And that continuing these regimens long-term is going to increase risk without that benefit. So, again, the brain is a little bit more complicated, but I have to say that the basic concepts of platelet inhibition to prevent thrombus and thromboembolism in patients who have atherosclerotic disease is very similar.
Okay. Well, again, thank you so much. And to everyone, stay safe, and same to you, Dr. Furie.
Thank you very much.
Yeah.
Take care.
Thank you.